fibrillation. Atrial fibrillation is actually fibrillary waves which is seen in the atria. Now, why is there fibrillary waves seen in the atria? So it might be secondary to cardiogenic cause, or it might be secondary to pulmonologic cause, or it might be secondary to some other causes also. Okay, so what are these other causes that will lead to atrial fibrillation, and what is actually atrial fibrillation? We'll be discussing in this video. So atrial fibrillation, so whenever we talk about atrial fibrillation, so atrial fibrillation is it's a chaotic irregular atrial rhythm at 300 to 600 beats per minute. Okay, so it's actually it's a chaotic irregular rhythm. Okay, it's a chaotic irregular rhythm. Now it's written in this slide that atrial fibrillation is the most common arrhythmias and occurs in 15% patients over 75 years of age. Paroxysmal form, stopping spontaneously within 7 days in younger patients. So if we divide atrial fibrillation into different types, then we can divide atrial fibrillation into, on the basis of duration and onset, into new, paroxysmal, persistent, long-standing and permanent. I don't know whether it's given in this slide regarding the so it's not given over here. So please note down. So atrial fibrillation can be divided into new, paroxysmal, persistent, long-standing and permanent. So new atrial fibrillation means less than 48 to 70 hours, 48 to 72 hours. So if atrial fibrillation occurs in less than 48 to 72 hours, then that is termed as new. Okay. Now paroxysmal form. So paroxysmal form means less than 7 days. Okay. So it's written over here, paroxysmal form of atrial fibrillation which spontaneously stops within 7 days. It is more common to young. Okay. It is more common to young age. More common to young age. Now, whenever we talk about atrial fibrillation, it's divided into new, paroxysmal. What is persistent? Persistent means more than 7 days is known as persistent. More than 7 days is known as persistent. Long-standing means more than 1 year means long-standing. More than 1 year means long-standing. Persistent means more than 7 days. Paroxysmal means less than 7 days is known as paroxysmal. New means less than 48 hours to 72 hours. So 48 to 72 hours is taken as new onset atrial fibrillation. New is 48 to 72 hours is new. Paroxysmal means less than 7 days is known as paroxysmal. Persistent means more than 7 days is known as persistent. Long-standing means more than 1 year is known as long-standing. And permanent means more than 7 days without any attempt to cardiovert the patient to normal sinus rhythm. Okay. So more than 7 days without any attempt to cardiovert the patient to normal sinus rhythm is known as permanent. That means, so if it's more than 7 days, we have to say persistent. Okay. But if it is more than 7 days without any attempt, so no attempt has been made. No attempt has been made to cardiovert the patient into a normal sinus rhythm. To cardiovert the patient into the normal sinus rhythm. If that's the case, then this is a permanent type of atrial fibrillation. Okay. So now let's move on to the pathophysiology. So we all know about the pathophysiology regarding atrial fibrillation. Beforehand of starting the slide, I told you that atrial fibrillation can be divided into cardiac or it can be divided into non-cardiac. Okay. So cardiac cause of atrial fibrillation is due to increase in the stretch of heart. It will lead to atrial fibrillation. So that happens in the case of congestive cardiac failure. So previously, when we were talking about mitral stenosis, we talked that whenever there is a stenotic lesion in the valve, right? That stenotic lesion in the heart valve will lead to more amount of blood in the left atrium. And more amount of blood which is present in the left atrium will lead to a formation of an ectopic units that will lead to formation of fibrillary waves. Okay, so you can see this ECG. Can you appreciate the fibrillary waves which is present in between the RR interval? So this fibrillary waves, we'll be talking about flutter in next video. Just concentrate in this above one. So there is this fibrillary waves which is present, and this is an irregular RR interval. So you can see the distance between the two peaks, QRS complex, two peaks. Just look into the distance. This distance, this distance, this distance, this distance, this distance, this distance, this distance. See how irregular it has become. So it's slightly larger over here, but it's smaller over here. Okay, it's smaller over here. It's again too much large over here. It's smaller over this one. So this is an irregular RR interval. Okay, and what's the patient's presentation? So the patient says that he misses a beat. Sometimes there is like severe palpitations, and actually the patient is having palpitation, but when he is having palpitation he misses a bit. That is the presentation of the patient of atrial fibrillation. So I told you certain cardiac causes of atrial fibrillation. The cardiac causes are congestive cardiac failure, mitral stenosis, mitral regurgitation, dilated cardiomyopathy, inflammation of the atria due to rheumatic heart disease, and hypertension. So basically all these causes leads to more amount of blood in the left atrium, and that atrium will beat like anything. Okay, it will be beating so rapidly. Okay, now what is the non-cardiac causes of this one, atrial fibrillation? So the non-cardiac cause of atrial fibrillation is COPD, pneumonia, acute pulmonary embolism. Okay, decrease in the level of oxygen, that is hypoxemia, will lead to atrial fibrillation. Okay, decrease in the level of oxygen will lead to atrial fibrillation. Thyrotoxicosis, increase in the level of thyroid hormones will lead to, yes, increase in the basal metabolic rate. Whenever there is an increase in the basal metabolic rate, that will lead to atrial fibrillation. Now, a lot of alcohol. So there is something which is known as a holiday heart syndrome. This holiday heart syndrome means a lot of alcohol. Whenever someone consumes a lot of alcohol, that can also lead to atrial fibrillation. Certain tumors like pheochromocytoma, where there is an excess release of epinephrine and there is an excess release of non-epinephrine, that will lead to increase in the sympathetic activity, and that can also lead to atrial fibrillation. Okay. Now, sepsis. So sepsis is a component of an infection, right? So there is an excess amount of catecholamine release, and that will also lead to atrial fibrillation. Okay, that will also lead to atrial fibrillation. So basically we comprised the different cardiac, non-cardiac causes of atrial fibrillation. Atrial fibrillation is chaotic rhythm of the atria, and that chaotic rhythm of the atria is secondary to formation of ectopic units. That ectopic units is formed in the heart, ectopic foci is formed in the heart, and that leads to arrhythmias where there is no P waves. So can you see here? Okay, so can you appreciate any P waves in this fibrillary waves? In this ECG, there are no P waves. A normal ECG looks like there is a P wave, and there is a PR interval, there is a QRX complex, and there is a QRX complex, right? But there is no any P waves, and there is fibrillary waves, and there is irregular RR interval in the atrial fibrillatory ECG, and that should be clearly stated. Atrial fibrillation, what are the causes of atrial fibrillation? There might be a cardiac cause, there might be a non-cardiac cause. Non-cardiac cause refer to the thyrotoxicosis, pheochromocytoma. Cardiac cause refer to mitral regurgitation, mitral stenosis, and dilated cardiomyopathy. Okay. Now, so patient can be asymptomatic sometimes. So we have already talked about some sort of symptoms in this finding. So there can be palpitations, fatigue. There can be fatigue. I'm not able to see who sees my presentation. I don't know why. Okay, so there is palpitations and there is fatigue. There is syncope. So why is this syncope seen? This syncope is seen secondary to the clot which is formed in the atrium when it goes to the blood circuit supplying the brain. Okay, there is sudden decrease in the level of blood supplying the brain, and that leads to syncope. Okay, so sometimes atrial fibrillation can lead to even stroke. So patient can land up into stroke. The patient can land up into lightheadedness. There can be fatigue, lightheadedness, syncope, and there can be angina. Okay, so all these features are seen secondary to um, atrial fibrillation. And remember, atrial fibrillation, the cause of atrial fibrillation, for example, someone is having thyrotoxicosis, will of course present with, okay, like increase in the level of thyroid hormones. They will present with like increase in diarrhea, so they might present with hot flashes, right? They are very very, they need a lot of this they want to stay in ACs all the time. That's basically hot. They're very very hot because of the increase in the level of thyroid hormones, and that increases the basal metabolic rate. Okay, now I already talked about the different manifest different this one. And complication is basically stroke. Okay, it's basically because of the embolism, and that can lead to heart failure also. Okay, they can also be in heart failure, and the complication is secondary to stroke. Now the management. So so basically we have already talked about the important aspect of atrial fibrillation. So let me just sum up everything for you. The heart is beating so fast, but the pulse is not synchronous, so there is also pulse deficit. Okay, that means suppose your heartbeat is 100, but your pulse will be 60. That means that amount of pulse, that amount of heartbeat is not being transferred as a pulse. Okay, so that is a pulse deficit, which is seen in the case of atrial fibrillation. That pulse deficit will be seen here. Okay. And we already talked about the causes of the atrial fibrillation, cardiac cause and non-cardiac cause. Please write it down in that way: cardiac cause and non-cardiac cause. Palpitation, dyspnea, faintness, chest tightness, right? Irregular pulse, irregular pulse, and pulse deficit. Now, how can we calculate pulse deficit? We can see an apical pulse, so you can just feel the, you can feel the heart rate, and then you just minus with the peripheral pulse, and that will give you the pulse deficit. Okay, pulse deficit can be seen. Now investigation, we can simply go for an ECG. In the ECG we will see absent P waves, you will see irregular RR intervals, and you will see fibrillary waves. Right? Now you can also have a look into the thyroid profile test, because I want to rule out hyperthyroidism. Do look into cardiac enzymes, because patient can present with some signs and symptoms like that of your angina. So we don't want to miss any kind of elevation in the cardiac enzymes. Go for an electrocardiography, go for electrolytes, and go for a chest X-ray. Now basic management of this patient is on rate control and rhythm control. Okay, so like in the cases of your initial case when we were talking about mitral stenosis, we talked about giving beta blockers and calcium channel blockers like diltiazem and digoxin, right? In the initial videos of mitral stenosis also, we talked about giving beta blockers like metoprolol or bisoprolol to decrease in the level of heart rate, right? The same drug we are giving here also. See, if someone is suffering from Graves' disease, so we can give Graves' disease plus AF, we can give beta blockers. If there is a systolic heart failure and AF, we can give digoxin. And asthma and AF, we can give calcium channel blockers. Okay, so it's the management protocol is divided into hemodynamically stable. Okay, we will move on to the slides in detail now. So the patient's management regarding atrial fibrillation is divided into three major gradings. One is if the patient is stable, okay, or if the patient is unstable. So the patient is unstable in this case, so it's also displayed in the slide. If the patient is unstable, he has hypertension, he is on shock, he is having MI, he is having heart failure. So our ambition in this case is not to go for a rate and this rhythm management. Our aim in this case is to revive the patient. So in this case we have to go for a DC cardioversion, right? And we are going to go for a synchronized shock which is started at 120 to 150 joules, and plus minus we are going to give amiodarone. Please understand this very carefully, that if the patient is unstable, we are going to go for DC cardioversion and we are going to go for an amiodarone. Okay, you have to also consider anticoagulant if the patient, when the patient is stable. Okay, but suppose the patient is stable. Suppose the patient is stable. Now, if the patient is stable, then atrial fibrillation is started less than 48 hours, or if it started more than 48 hours. That's our concern. So if it is less than 48 hours, we can either go for rate control or rhythm control. But if it is already more than 48 hours, rhythm control becomes a later option. First option is rate control, with either we can use beta blockers or calcium channel blockers. So beta blockers we can use like bisoprolol, and calcium channel blockers we can use like diltiazem, right? Now if the AF persists, you have to go for cardioversion. So you can see here, hemodynamically stable patient, you can either go for rate control or you can either go for rhythm control. Okay, if it is less than 48 hours, we can go for rate or rhythm control. Rhythm control can be done by DC cardioversion, or we can also go for flecainamide. Flecainamide can be given. Remember one thing, that if the patient is unstable, directly go for DC cardioversion and then you go for anticoagulant, and amiodarone is very important. Okay, now rate control can be done with beta blockers or calcium channel blockers, right? Rhythm control can be done by either DC cardioversion or we can go for flecainamide. Okay, now rhythm control generally appropriate in patients who are less than 65 years of age, highly symptomatic, patient with heart failure, okay, and individuals with recent onset MI. See, I already classified atrial fibrillation into recent onset, into persistent, into permanent, okay, into paroxysmal. Okay, so new onset of atrial fibrillation means 48 to 72 hours is considered to be as a new onset of atrial fibrillation. In this new onset of atrial fibrillation, we can go for a rhythm control. Okay, but if the atrial fibrillation has already been a persistent or a permanent, it is better we start with a rate control, then only we go for rhythm control. Okay, so if the age is less than 65 years of age, highly symptomatic patient with heart failure, individuals with recent onset atrial fibrillation less than 48 hours, we can go for rhythm control. Rhythm control in stable patient can also be done with the help of flecainamide. Okay, never forget to calculate Shatbach scoring system before you discharge patient with warfarin. So of course, we will be discharging patient with long-term anticoagulant therapies needed. AF is associated with increased risk of thromboembolism, and anticoagulation should be given for at least 3 weeks. Okay, so anticoagulation must be given for at least 3 weeks before, with the exception of those who require emergency cardioversion or new onset AF. In this case, I want the INR to be 2 to 3. We can also give newer drugs like direct XA inhibitors like rivaroxaban, and we can go for direct thrombin inhibitors like dabigatran. Okay, direct XA inhibitors is rivaroxaban, which is extensively used, better tolerated than warfarin, but INR must be 2 to 3. Okay, and Shatbach scoring system is very important. So Shatbach scoring system refers to congestive heart failure, hypertension, age, and remember this age. So age is given as 0.2. Okay, diabetes, stroke 0.2, any kind of vascular disease, again age more than 65 years, given point as 1. 6, if it's a female, it's given as 0.1, and total score if it is maximum score is the 9, and if it is 0, 1, 2. So if it is 0, no therapy or aspirin, okay, one aspirin or oral anticoagulation, okay. And if the score is more than or equal to 2, it is oral anticoagulation that has to be given, okay. There's also another score which is known as Hasgled score, which is to be calculated concurrently, okay. This completes our video on atrial fibrillation. Thank you.